2 lançamentos acontecendo a nível Brasil, lançamentos de materiais internacionais desenvolvidos pela Organização Mundial da Saúde e Organização Pan-Americana da Saúde, e pela primeira vez no Brasil, aqui dentro do nosso evento do Fórum. Então, I'll thank you very much, Pedro de Paula, for accepting our invitation to moderate this panel. And obviously, I'll thank Neda, Guy, and Anselm Hennis for accepting our invitation for this so important moment for us all here in Brazil, to have this opportunity to learn from you and to share with you. Thank you very much.
Thank you, Mark. Thank you for the Fórum of DCNTs in Brazil, the NCDs in Portuguese. It is a great honor and a privilege to be here representing Vital Strategies with this such a high level panelists, and in such a critical moment for NCDs aggravated by the pandemic, as we have been hearing for the past hours in the initial remarks of our advisory members. So here today we have the honor to have Dr. Guy Fons, Dr. Nida Milewska, and Dr. Anselm Hennis. They are from WHO, PAHO, and the International Alliance of Patient Organizations. I'll introduce each of them in their respective considerations. And not only we will discuss NCDs today, but we'll have 2 important launches, and we are very glad to be part of this. And each of the panelists will have 15 minutes for their presentations, and then at the end we'll ask you participants to send questions so that we can ask our panelists questions and get their answers on the critical topics that you certainly address here. So if I'm not mistaken, we'll begin with Dr. Guy Fons from WHO. He is the acting head of the coordination mechanism for NCDs. Correct me if I'm wrong, Guy, and thank you for your participation. It's a pleasure to be here with you.
Thank you, Pedro. Thank you, and welcome, and great to be with this very interesting panel. And then hello and good afternoon, or good evening, or good morning to all who have joined this interesting discussion. First of all, I may disappoint some, but I am not actually the original presenter in this panel. The original presenter was Jack Fisher. He's one of my team members, and he's actually the lead in what we're going to announce now as one of the launches mentioned by you, Pedro. But I'm head, and not acting head either, but I'm head of the Secretariat of the Global Coordination Mechanism at WHO in Geneva. It's a pleasure to be with you. It's not the first time I'm supporting your initiatives. We have had a long history of active collaboration, either at Brazilian level, at regional level, or at global level, with DCNTs. And this is one more of those opportunities. What we're going to present now has been also done in collaboration with participants from Brazil and from DCNTs, including Mark. So glad to see you, Mark, again. I've asked to share the slides from your end because I'm having difficulties with my internet connection. So let's see if that's possible. Thank you so much. Here we are. So what I'm going to present today is actually the launch of a report. The report is Nothing for Us Without Us. Next slide, please. And while we're extremely proud of this report, I really want to send the message that actually underpinning the report is the visibilization and the prioritization of extremely critical concept and critical platform that has long been underserved and underused in the NCD narrative. And that is the meaningful engagement of people living with the diseases, meaningful engagement of people living with NCDs. I believe that for the last 30 years, this has been an underused, underserved, and misunderstood platform and and concept within disease prevention, disease promotion, and policy development. And I say 30 years because I'm actually thinking about other global health agendas that have moved forward in the last 30 years extremely successfully because they have been able to understand the power, the value of lived experience, the expertise of lived experience in development, discussion, development, design, implementation, monitoring, et cetera, on policies, programs, and services. And it becomes so extremely relevant and urgent where we sit now today, where people living with NCDs have been so underserved historically, but then has been exposed, dramatically exposed, how people living with NCDs have been in a vulnerable situation for decades, exposed to the COVID pandemic. So this report, I said, marks the milestone of this very, very important 3-day WHO informal consultation with people living with NCDs. It has been a long journey of trying to put together some of the pieces of the value, lessons learned from other programmatic areas, frameworks exist piecemealed here and there at global, regional, and national levels on success stories and how some of these frameworks have been working. We have put this together and brought together in a 3-day consultation from which we will look at this report with a bit of depth. But the more important thing is that also this report marks a milestone of the way forward, of how we can truly operationalize meaningful engagement, not only within WHO, but within the global agenda for NCDs. As you see there, this was a 3-day participatory meeting, and we will look into that in a bit in the following slides. So let's go to the next slide, please. So why have we identified this platform and this, as I call it, a concept? And it is because the NCD agenda, the NCD community has been lagging behind in understanding that to bridge a global development, one of the main development challenges of the 21st century, to bridge that with the attention to building back better, the attention that the SDG, the commitment that the SDG places on us all to leave no one behind. How do we bridge leaving no one behind in a situation where we are faced with one of the major global epidemics, exposed even further through the COVID? What can we do to ensure that some of the policies, programs, and services we will build back better after COVID do not leave people behind? And one of the answers to that is the appropriate attention to the expertise of lived experience in shaping those policies, programs, and services that will ensure that we do not only build back from the devastating impact of COVID, but we really build back better. As WHO Director General, Dr. Tedros, said very well in the opening statement of this meeting, is as we work to build back better, we must engage with civil society and individuals with lived experience to hold WHO and political leaders accountable and to drive change. WHO values your voices, your expertise, and your inputs. And Dr. Tedros is also committed to leveraging WHO's role in supporting our member states in doing the same. Highlighting, I just want to land on one word highlighting here, is that the WHO through DG Tedros values the expertise. And I think that's one of the main messages coming out of our consultation, but of our long activities to try to collect the data, the evidence, and the narrative, is that people living with diseases have an expertise of their own. They have multi-layered expertise, and which has to be channeled into policies, programs, and services. Next slide, please. So how was this particular consultation developed? Well, the GCM, as you may or may not know, the Global Coordination Mechanism, which I lead, is a very innovative platform within WHO. It's an engagement platform. Its particular purpose is to facilitate, catalyze, knowledge share, capacity building across the different stakeholders relevant to NCDs, certainly with WHO's resources, expertise, and knowledge, but also convening that knowledge, that expertise, and those resources from beyond WHO and within that very rich and diverse stakeholder base, and not only with civil society, but certainly across private sector, relevant private sector entities, and when and if appropriate, certainly, but also UN agencies academia, philanthropic foundations. So we've been able to leverage that expertise and bring that relevance, and especially of people living with diseases themselves, not only NCDs, but other programmatic areas which have so much to teach us in the NCD arena. And I refer specifically to the HIV AIDS community, which they have been very vocal in insisting that a game-changing moment, a pivotal moment in their response, in the HIV response, was when they understood how, when, and through what platforms to really engage people living with HIV, and involve them in decision-making processes. A game changer. We haven't been able to identify that. HIV community identified 20, 25 years ago. We are still lagging behind in the NC community. It is time to change, and the COVID situation has placed us with an extremely fast ticking clock to be able to do this. We think that this consultation and this participatory, co-led, co-created participatory approach of this consultation will open the door to several activities that we will touch on in the coming slides. So next slide, please. So what are the objectives of the consultation going into the first day? Certainly, these are the three main. There were many other objectives of sub-objectives that we identified even going into the second and third days, but the main objectives were to explore the value of meaningful engagement, and certainly building on the lessons learned from other health programs and health areas. The value of meaningful engagement, which may seem obvious to civil society in general, may seem obvious to many countries and subnational local levels who are already extremely successful in engaging communities, engaging lived experiences in policy and intervention implementation. It is not that obvious at global level, and certainly not obvious at the global NCD community. So really understanding the value of meaningful engagement, and through the expertise and how we can shape frameworks to meaningfully involve those experiences in our policy design, policy development. Also, as a second objective, we also need to identify activities, work streams, platforms that are already existing, and not only within the NCD agenda, but in other programmatic areas that we can already start inserting, engaging people living with before we even think of starting new platforms. It's certainly not about reinventing the wheel. It's extremely successful platforms under UHC. Engagement platforms on UHC, I said, engagement platforms for developing the SDG 3 action plan, engagement platforms for HIV, for maternal and child health, where we need to think about cross-cutting policies, cross-cutting conversations, and integrated approaches that can support primary healthcare. So sort of integrating these platforms of meaningful engagement and inserting the attention to people living with NCDs in the platforms is extremely important going forward. And then the last objective was to really define next step of how we can really go ahead, next steps, and operationalize that meaningful engagement with particular relevance within WHO structures, but also then how can WHO support the operationalization of meaningful engagement across other platforms, other stakeholders, and certainly at regional and national level. Next slide, please. And these were the questions that try to guiding those objectives. What does meaningful engagement really mean to the community, to those participating? How do we engage meaningfully? And where do we go from here? Underpinning sort of the three objectives. Next slide, please. And all of these are some numbers, I'll get to that, but all of these questions and all these objectives are very well unpackaged in the report. I'm just going through very briefly, inviting you obviously to read the report and look into more detail. But so going into the consultation, one of the main objectives was that this consultation should already be operationalizing meaningful involvement, and I think we hit the mark very well. You'll see that there was 37 countries represented, 54 of the participants identified as persons living with NCDs, and the gender geographical balance you can see there. That we also had 16% of participants identifying with a disability. And importantly, the stakeholder groups, certainly civil society and non-governmental organizations were included, but we did invite UN and WHO and other UN agencies, academics, independents. It's a very strong collection of experiences, if you will, and really paying attention to the intersectionality, so the different layers of lived experience, really paying attention to the, policies on the ground, policies in primary healthcare, community level interventions, really need to understand the intersections of so many different layers of lived experience, not only with diseases, not only with the sole disease, not only with the sole NCD, comorbidities across the NCD agenda, comorbidities with other programmatic areas, communicable diseases, for example, and NCDs, but also intersections, healthcare, professional experience, healthcare providers, family members, gender issues, cultural issues. The intersection of layers of lived experience is so important to really hit the mark at community level on the ground and really leave no one behind. Next slide, please. So, and the emergent themes that you also see unpackaged in the report ultimately the conclusions, the emergent themes in a sense, are that meaningful engagement actually activates agents of change. And those agents of change will populate our policy design, our policy implementation, our advocacy efforts, our communications efforts, and our political discussions. So how can we ensure capacity for those agents of change? What is needed? Resources, financing, structures, formats, workshops, at what level? Global, regional, national, subnational? How can we ensure sustainable capacity building of agents of change? Also, a main theme was from talking the talk to walking the talk. I am actually talking the talk. I should be more walking the talk. At this moment, we are, as from my office now, after the report, we're going to start walking the talk by implementing some of these actions that were identified in the report, and we invite all of this community to join us. And the last part was what are exactly those actions we want to see? Next slide, please. And these are the next slides. I don't have many more slides. These are one of the few, the last ones. But our next steps that we invite all of you to join us, and we have structured particular activities and interventions are those following. The top row really is that really was identified in the consultation and beyond, is that there's a huge lack of data, evidence, best practices, case studies on what really is happening in the NCD agenda and what is the impact of meaningful engagement in those areas where it has been successful. So we will start mapping best practices and case studies. We will explore alignment, integration with other lived experience communities, also conduct extensive stakeholder mapping on that intersectionality and what do we have to think about when understanding the representation we want at the table. Is it across diseases, across geographical, contextual specificities? How can we start mapping the necessary stakeholders we need on the table? The other is to conduct additional focused contextual consultations like the one we had, but certainly reaching more and more towards the community level. Can we have those consultations at regional, at national, subnational, community level with your support? And then the last, the line at the bottom is, well, then when we have that data, how can we go forward? We need to renew advocacy support for those agents of change, the capacity building for those agents of change by identifying funding models, for example, and models, frameworks for the sustainable and formal inclusion of people living with these structures. And from then co-create an action plan with people living with disease, and what we are calling a WHO framework of engagement with people living with NCDs. Next slide, please. Please let me know timing. I tend to be very passionate about this and talk a lot, but you just cut me off. All right. So this is a busy slide. I won't go through all of it, but it really is that what the conclusions. The conclusion is, I've mentioned some of them across my slides. Conclusion is that lived experience is an expertise in itself, and that is not truly understood in the NCD agenda. We need to move from tokenistic participation to real decision-making processes through the expertise of those lived experiences, formal, sustained participation, and not just tokenistic. And that really is by meaningful, respectful, and inclusive involvement. Across the value chain of policy design, development, implementation, monitoring, and accountability, which is so important. And then the ultimate thing is that maybe I'll summarize that all of this information and all of this activities and next steps, which we'll be developing into 2021 and in the beginning of 2022, it will end up hopefully with a very impactful and clear and precise WHO framework for meaningful engagement of people living with NCDs, which will serve as a basis for operationalizing meaningful engagement at regional level, and certainly, we hope, more importantly, at national and subnational level. So we will be contacting you for sure during this process, during the main activities, to accompany in this journey, to really prioritize and have that game-changing moment, that pivotal moment that the HIV community shares with us all the time. This is a pivotal moment when we can shape policies, shape programs for inclusive attention to people living with NCDs. Thank you so much. Back to you, Pedro.
Thank you very much for this inspiring and very detailed presentation on this quite important publication, but not only the publication, but the framework for meaningful engagement of people living with NCDs is a huge step towards providing better systematic engagement of people living with NCDs in policymaking, in agenda setting, for many reasons, and the whys and hows of these are going to be more thoroughly addressed by Dr. Nida, who we couldn't have a better person to address this issue than her. So I'll move ahead to her. Please, Dr. Nida.
Thank you, Dr. Pedro. Is it also possible to have the slides shared from your end, or I can share myself? In the meantime, thank you very much. Brilliant. Good. Is that okay? Okay. Thank you, Dr. Pedro, once again, and I would like to thank the forum and the presiding Dr. Mark Barone for inviting me to speak at this very distinguished panel. To really also thank Dr. Guy for giving this very good presentation of the initiative that the WHO has taken on board last year with the consultation. And I can say that we are really, as him, first of all, we are very grateful as a patient alliance that such a process has taken place, but we are also very proud of what has been discussed during those 3 days, because our members have also participated, and that is a true confirmation that whatever was said was really happening, that the people living with MCDs were heard. If I can have the next slide, please. My name is Neda Milevska-Kostova, and I'm the Vice Chair of the Governing Board of the International Alliance of Patient Organizations. It was established in 1999. We represent more than 280 patient organizations and patient alliances, addressing the needs and sharing the voice of more than 1 million patients. They're based in more than 70 countries and represent more than 50 disease areas. Our vision is to see the patients at the center of healthcare, and the mission is to really try to build that kind of a system together with other stakeholders. Obviously, we believe that patients need to be at the center of the healthcare, because that will help not only the individual patients, but also the healthcare systems and the society at large. Next slide. So I was asked at this presentation to speak about why, when, and how to engage the persons living with chronic conditions. I would like to quote at the beginning Sir William Osler, who said that the good doctor treats the disease, but actually the great doctor treats the patient who has the disease. And we can simply extrapolate this also to health systems or to health policies. As Dr. Guy rightfully said, if we do not meaningfully engage people living with the disease throughout the entire cycle and the process, this will not really give us the impact or the desired results that we would want. So just to illustrate, if we have a person living with a chronic condition, they may be coming in the contact with the healthcare or social services systems a number of times in the day. Even by taking the pill, they are reminded that they have this disease, but otherwise 24 hours they have to live with that experience. And again, as rightfully said, this experience is something that we can use not only in the creating of the policies, but in implementing them. If we go to the next slide, which I will not really elaborate in details because it was the ground for why we need to engage each individual stakeholder was really very well laid out by Dr. Mark in the earlier session. It was in Portuguese though, although it was really very clear that we are still very much struggling with NCDs being the silent killer of more than 70% of mortality occurring due to the chronic diseases. And while everything was overshadowed by COVID, and obviously reasonably so because we have an acute situation to handle, this other underlying condition has not been waived or cannot be really waived. If we go to the next slide, although I don't think that these are the last version of the slides, but in any case, now, having the why and the 70 more percent, as I mentioned, of those mortality cases, actually 1/3 of them are premature deaths, something that we would all want to see waived from the map, wiped from the map, in the sense that those are not only economic costs, but those are lost lives of the dear ones, or lost opportunities to thrive, lost opportunities to see someone graduate, or lost opportunities to see someone get their own family. So beyond setting up that, it is important also to discuss when. And I would say that it was fairly well described by Dr. Guy, that, thank you very much. Now, as it was mentioned, people living with the disease, they have their own expertise that they live throughout 24/7. So the question when they need to get engaged is, I think the answer is right now, or at any time, because they really live 24 hours with their expertise. Now, it is very difficult to expect that any policy having their own living cycle can introduce anyone at any particular moment that they have. Next, please. But then again, that policy cycle that has its own steps and its own living model, it coincides a lot with many of the roles that the patient can play. And this is only to illustrate. If we go to the next slide, maybe we can see in more details how we at IAPO envisage the involvement of patients. Next slide. How we envisage at IAPO involvement of patients in across the cycle. So in 2020, just to go back to one of the earlier slides, without going back to the slides, I just want to refer to something. In 2020, International Alliance of Patient Organizations, being the alliance of patient organizations, has considered that we need to also change the way in which our constituency is involved. So instead of just waiting for the policies to change or waiting for a government to craft whatever we would be expecting to be a meaningful policies for our well-being or quality of life, IAPO established the IAPO Patient for Patient Safety Observatory, which is really supposed to be building across the 3 pillars of potential and possible engagement of patients and caregivers. And as Dr. Guy, I will refer once again to him, as he mentioned, to avoid as much as possible the tokenistic approach and to avoid as much as possible only the single storytelling. We notice that there are many conferences in which we are invited, or there are many places of discussions and policy dialogues where the narrative, the patients are invited only to fill in the story with the narrative. And that is still just a very anecdotal way of involving them. So our Patient for Patient Safety Observatory is intending to fill in this gap by addressing and building the capacity of patients with these 6 roles. So we all know that patients have been involved. The top 3 roles are even now present. Patients participate in clinical trials, they participate in qualitative studies through interviews and so on. Sometimes they are advisors to governments, but the latter part, the latter three roles of the patients are still not as much fulfilled. So we are trying to build the capacity of the patients to become reviewers of specific policies, or to be reviewers of the research, even to be co-designers, and finally to be the driving force. So using this experience and expertise, lived experience that Dr. Guy and Dr. Mark and other speakers earlier have mentioned. And by saying this, next slide, we would like to really bring that experience and expertise through the three tiers that we have developed through IAPO and through our new observatory, and that is to empower the patients, or to empower the caregivers or patient organizations through different trainings, development of tools, advocacy, and so on. So to equip them to a more objectively, I know it's very difficult when we say to objectively, because they live subjectively what they live. However, to try to give them the tools into their hands so they can objectively and meaningfully engage. And the second one is really to try to engage them into the research beyond the research subject role, as I explained in the earlier slide. And the third one is something that also Dr. Guy was mentioning, and Dr. Patrizia in the explanation of the Brazilian case, that actually we would like to also see them shaping the policies and being involved in the policy making and in shaping the policies beyond the anecdotal level. So to give them a more robust knowledge, to give them a more significant training on how they can step aside as much as they can from their individual situation, to bring it objectively on the table, and to try to really participate in any policy dialogue, or at the individual level when they discuss with their doctors and so on. Next slide, and I think we are nearly done. So this was all talking the talk, as mentioned earlier, but just to try to bring to your attention something that I think would be of interest for all of us to engage in contributing to these debates. And I believe that these three calls for experts are really part of the walking the talk that it was mentioned earlier, that beyond the report where we heard how persons living with the disease can be engaged. These are the next steps of WHO creating the technical advisory groups on prevention and control of NCDs, on research and innovation, and one specific one on diabetes. I have listed only three because their deadline is coming up next week. Please look out for those, not only at the WHO, but the UN also. They have a policy dialogue on antimicrobial resistance also next week, to which we can submit questions on how we want some aspects of that addressed. And I'm mentioning antimicrobial resistance here specifically because although it sounds very far and distant from NCDs, antimicrobial resistance is really affecting people with non-communicable diseases, and especially people needing surgeries, people needing immunosuppressing therapies, and so on. So all of these types of consultations we need to engage as much as possible. These are only listed as a global ones, but there are regional ones. There are some, I'm sure, on national level. I'm so sorry, I cannot really try to find those ones that you might be interested in the Brazilian context or in PAHO context, but please look out for those and engage as much as possible, either individually or through your alliances, through your patient constituency, because it is about engagement. It is about speaking up what we have lived through, and our observatory will be trying to give the necessary capacity to make it more tangible, or to make it more closer to a policy-making jargon, if you wish. Next slide, which really has only a couple of takeaway messages. And I think most of it has already been said. But just to reiterate that we at IAPO believe that the systems exist for people and not vice versa, and that systems that exist right now were created to put a structure, but the main aims somehow we lost on the way. Now this COVID and maybe these other underlying conditions and pandemics like NCD or AMR are really giving us the opportunity to rethink and to build back better, as it is now becoming a very common phrase. And societies should really try to create systems for and with people rather than systems that are structured around diseases or facilities. As Sir William Osler said, we need to treat the person and not the disease, because that person has their own wishes, dreams, desires, and so on. And those persons have living experience, and they know the art of how to convert challenges into opportunities. Just one last click, and I will thank you all. Next, please. And just I want to finish by saying that the wealth of a society is not a goal in itself, but it should be a means for ensuring good health and well-being and quality of life. For the longevity is just something that we want to all enjoy as a nations, but as individuals as well. Thank you very much.
Thank you so much, Dr. Nida, for your inspiring, detailed, and very knowledgeable presentation. I think it's quite important for us working with NCDs to meaningfully engage people living with NCDs, not only in the storytelling, but also in the storytelling, but with their knowledge and expertise in substantial contributions and co-creations to the policies that they will be implicated in. So with that, I'll invite Dr. Ansam Hanis from PAHO WHO to discuss here the Global Diabetes, actually launched the Global Diabetes Compact in Brazil, which is actually quite important for this forum, as this NCD forum in Brazil, this DCNTs, as we say in Portuguese, has a strong correlation with diabetes patients associations. Mark and many of the members here have this history. Dr. Ansam Hanis, please welcome.
Yes, good morning, Pedro. Pleasure to be here. Good morning, colleagues. Good to see familiar faces again. Good morning, good afternoon, good evening to those participating otherwise. And it was really quite refreshing to hear about Sir William Osler, because one of my professors when I was in medical school was a student of Osler, and so I heard about Osler all the time and I bought a number of his books. So it was quite great to hear about it and the importance of treating the person and not just the disease. So thank you so much. Now my slides are actually with you, so I'll be very happy if they put the slides up for me so I can begin the presentation. Wonderful. Okay, thank you so much. Let's move on to the next slide. And we're talking about the WHO Global Diabetes Compact and the relevance to Brazil. Why should we focus on diabetes? We know it's a growing epidemic. There's a rise in global deaths, which have increased 70% since 2000. The premature death rate has also gone up 5% since 2010. And there's also an increase in the number of people diagnosed with diabetes. It's expected to increase from 420 million today globally to 570 million by 2030 if nothing is done to reduce this and turn back this trend. What are the drivers? Certainly obesity is a major driver, and that's increased 150% globally since the year 2000. Diets, physical inactivity are all drivers for this situation and responsible for 20% of premature mortality worldwide. We still have inadequate diagnosis and access to treatment. The majority of people with diabetes live in low and middle income countries, and they just don't have access to the necessary healthcare. Even though this year commemorates the 100th anniversary of the discovery of insulin by Banton and Bess at the University of Toronto, 50 people with type 2 diabetes don't get the insulin that they need. Lack of access to primary healthcare. We talk about multidisciplinary approach to diabetes in care. It remains a concept and a construct for most health systems. It just does not exist. Health literacy is also lacking. Diabetes health services are not included in universal health coverage. And as we heard in some of the presentations before, the impact of COVID-19. What we've seen in our region is that as many as 50% of services for diabetes and diabetes complications have been impacted directly because of COVID. And the costs, of course, for managing diabetes are high. Next slide, please. This is a slide of the prevalence of diabetes in the Americas. 62 million people have diabetes. Overall regional prevalence is 8.3% and is highest in the Caribbean countries at 11.8%. It affects women more than men, and the rates are higher among indigenous populations. Brazil, which is the fifth from the bottom or so, has a prevalence rate of about 8.5% for diabetes. Let's go on to the next slide. Now, these are the diabetes trends in the Americas, and the actual global mandate in terms of the Global Action Plan has been that there should be no increase in diabetes or obesity. We can see from this slide quite clearly that the rates of diabetes continue to track upwards. So we will not achieve this global target. Next slide. Good. Now, what are the underpinnings? And I alluded to it before. Now, this slide shows the men in the green bars, the women in the red bars, and it does a comparison of all the 6 WHO regions. You'll notice there's some circles in orange with number 1. And those circles are the ranking of the region of the Americas. So the first number 1 is the prevalence of physical inactivity in adults. The region of the Americas is first. Then the other 3 ones, one under the other, are all about the prevalence of overweight and obesity in adults, the prevalence of obesity in adults, and the prevalence of obesity in adolescents. So we have the 2 drivers existing hand in hand, sedentarism and overweight and obesity. And these are the key drivers for the diabetes epidemic that we're seeing in the region of the Americas. Next slide. So in terms of the global diabetes compact, what is the vision? The vision is to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality treatment and care. And that speaks to the presentation we just had about the importance of those who are suffering. Let's go to the next slide. So that's the vision. Next slide. And this is the mission. Creating choices for countries in the face of complexity for diabetes prevention, early diagnosis, treatment, care and rehabilitation, whatever the development context, and to create the conditions for new ways for governments, UN organizations, civil society, philanthropic foundations, businesses, academic institutions, in other words, all the agencies, and most importantly, for people living with diabetes to power ahead together, faster and further than before in bringing diabetes care to all who need it. This is a whole of society, whole of government, whole of nation, whole of world effort to tackle and change the trajectory of diabetes. Next slide. So what are some of the objectives? To protect, to detect, to treat, and to recover. To protect means reducing major diabetes risk factors through policies and fiscal measures. To detect, which means improving the diagnosis and treatment of diabetes as part of primary health services and universal health coverage benefit packages. And as we know, many people have diabetes for several years before it's detected. And it's at least 7 years that people remain undetected with diabetes in many societies. Treatment is important to scale up access to essential diabetes medicines, including, as I said before, instant, as well as technologies. So, if you're not able to measure your blood sugar and have glucometer access and so on, and even have insulin dispensing devices and syringes and so forth, the overall outcomes are not as good as they could be if the technologies and medications were available. And of course, recover, protecting people living with diabetes from COVID and vice versa, and building back better. Next slide. So what do you hope to achieve? In the protection, more people covered by at least one measure to reduce risk factors, dietary, etc., salt, sodium, sugars, increasing physical activity, improving tobacco control measures. And of course, in terms of detection, more people benefiting from available and affordable diagnostic tests for diabetes as part of primary health care. And of course, more people benefiting from diagnosis and treatment through universal health coverage. So that's on the detection. The expected outcomes are that more people will be who are diagnosed with type 1 diabetes will have access to insulin. More people diagnosed with type 2 diabetes will be managed by a blood glucose management protocol, which includes access to insulin for those who need it. And of course, more people screen for chronic complications and get the care they need. And as we know, diabetes is linked to neuropathies, retinopathies, et cetera, et cetera, et cetera. So a lot of morbidity linked to diabetes. And quite often, many health systems do not provide adequate screening, detection, and management. And then, of course, the recovery phase. There must be diabetes included in the domestic health response to COVID-19. And we're talking about a transformative recovery process that addresses inequalities, exclusion, and gaps in social protection. Let's go on to the next slide. And of course, as I said before, we are not doing very well in terms of reducing premature mortality from NCDs by a third by 2030, or in terms of covering all people with universal health coverage by 2030. So I spoke a little bit about the gaps in terms of the targets, and there's much work to do to achieve these existing targets. Let's go on to the next slide. So what is the health system response to diabetes in the Americas? We have to improve diagnosis of diabetes, treatment, and self-care. As I said before, 20% of countries have specific plans for diabetes. 48% of countries have specific goals to reduce or control diabetes as part of their NCD plans. 74% of countries in our region have available medicine supplies for diabetes. But clearly, access to many of these medicines and technologies remains a challenge. And I will highlight in this context the importance of the PAHO Strategic Fund, which allows procurement as well as technical cooperation, which makes medications available to countries at the best price as they're selected through the WHO essential medicine list. But what we're seeing is, even though we offer affordable diabetes medicines and supplies, there's been very little uptake for these services in the region of the Americas, which is really quite a shame, because some areas, for example, HIV, have benefited tremendously. And I think really we have to capitalize. Next slide. Right. Well, I wouldn't say much about nutrition and diabetes. Nutrition in Brazil. Brazil is an example of having the best dietary guidelines in the world. Let's go on to the next slide. And in terms of tobacco control, Brazil is a global champion. As you can see, the rates have gone down from 90% to 13% with all the various policies implemented. So they've done very, very well. Next slide. Good. We're on to HEARTS. What is HEARTS? HEARTS basically is a technical package that improves hypertension control in primary healthcare. So it's based on a team-based primary healthcare approach, patient-oriented. It uses evidence-based treatment protocols. It promotes healthy lifestyle, access to medicines, risk-based management, and referral, and systems for monitoring. And these are the pillars of HEARTS. It also contains new criterion for the diagnosis and management of type 2 diabetes, which is known as the HEARTS-D protocol. And so if we can implement these strategies successfully in primary healthcare, the evidence has been that you reduce mortality from cardiovascular disease. This has been shown to the Kaiser Permanente experience in North Carolina, in Northern California. Next slide. To date, HEARTS has been implemented in 12 countries of the Americas, and now Brazil, I understand, has signed on and will be joining this noble enterprise to strengthen the delivery of NCD management in primary healthcare. And we are quite sure this will make a tremendous improvement to the outcomes of the Brazilian population, coupled with what's already been achieved. Next slide. Next slide. Obviously, we won't leave anyone behind. Let's go on to the next slide. Next slide. Right. So there are a number of issues that, yes, thank you. The objectives that we need to do are to reduce childhood obesity, increase physical activity, reduce tobacco control, and pursue equity-based approaches. Next slide. And then clearly regarding detection and treatment of obesity and complications, we have to strengthen primary health care, manage the comorbidities. We have to build back better and strengthen universal health coverage, as well as expand access to care for diabetes management. Next slide. And this is all under the Global Diabetes Compact. Strengthening surveillance is also an important element of what we need to do, which includes surveys, digitalization, and strengthening registries, particularly for diabetes. Next slide. And of course, as you know, there's been a tremendous impact of COVID in Brazil. We've heard about it in details. I won't go into it in any great detail. Let's go on to the next slide. But certainly, what I will say is that some countries, particularly Mexico, has used HEARTS to strengthen their response and approach to NCDs in COVID. Next slide. So in conclusion, the diabetes prevalence and mortality continues to increase in the Americas. We need to improve the detection and control rates. The Global Diabetes Compact can accelerate improvements in diabetes care. We need to strengthen integrated management of diabetes and hypertension, which is part of HEARTS, in a primary healthcare system approach to achieve this. There are a number of tools, resources, and technical assistance available from PAHO and other partners, and the COVID pandemic has exacerbated the need for health systems strengthening and innovative strategies to manage NCDs, including diabetes. Thanks for your time. Thank you.
Thank you so much, Dr. Anselm, and thank you all panelists for your great presentations. We have opened the Q&A box here for the attendees' questions, and I have already two questions here. One was sent in the chat and another one in the Q&A. So I'll start with this first set, and then we'll get more. And I have myself a couple of questions here as well. So the first question, I think it's addressed to Dr. Guy and Dr. Nida on, are there any recommendations on how to educate decision makers to engage people living with NCDs with decision power at decision tables? And I already also asked Dr. Anselm the question that was addressed to him. So I just received a comment that my microphone is low. The sound is very low. Can you hear me well? Okay. So Dr. Anselm, considering obesity as one of the main risk factors for diabetes development, is there any suggestion protocol from PAHO, WHO for tackling obesity? This was sent by an anonymous attendee, so I can grab it. So this is the first round of questions, and I will follow up with the second round. Dr. Guy?
Thank you, Pedro. Yes. And thank you for that presentation, Dr. Hennis. It's very, very important. Very important. The Global Diabetes Compact will really be a game changer in the NCD arena, and it will be used as a pilot test of this global regional and country initiative on an NCD. The question is a very important question, and it has to do basically with health literacy, ultimately. And it is, how do we empower the different levels of the policy development chain? So while we're empowering the agents of change to push for change, we need, from a bottom-up approach, we need to ensure that the top-down system is working efficiently. That the top-down process from policymakers, parliamentarians, government leaders, ministry, focal points, community leaders, have the necessary tools, knowledge, resources, and health and literacy to understand the impact of policies and programs. And that's a really important process in the empowerment of. We had a very important quote from our consultation. When you empower communities, you empower the whole system. Meaning that if we focus on empowering the community at the community level, it will eventually percolate as a bottom-up approach to mobilize and empower political leaders. But that is also wishful thinking. So the health literacy of policymakers is extremely important. That has to go in parallel with the empowerment of communities. And at WHO, we are working on health literacy approaches across that organizational levels, including political and parliamentarian levels. We are bringing together in a sort of in a virtuous connection between parliamentarians, science brought by WHO and others, and civil society agents of change. We're trying to make that change at the political level. Now, we have extremely good examples elsewhere beyond NCDs. The UHC movement has done extremely well, and the HIV, communicable disease, has also maternal and child health environment, and they have excellent examples of empowerment of not only community level, but also at the political level. We are learning from those experiences and eventually channeling those into our health literacy efforts with politicians and policymakers, but that is extremely relevant. We need to ensure that we are building the capacity and the empowerment from the bottom up, but also at the same time in parallel from top down. And they need to meet in a very interesting and collaborative effort to really look at those the impact of policies and programs. That's my initial comment, but I think that's a very good question.
Dr. Nida?
Yes, thank you, Pedro, and thank you, Dr. Guy. I really couldn't agree more. I just want to add that we also need to perceive those policymakers and decision makers with the decision-making power as part of those communities. So maybe that will change their approach in how they're perceiving any issue when they have turned the tables, as we like to say. And that is exactly what we are trying to do with this observatory, to narrow the language barrier, if you wish, between those that are living with an experience or coping or converting their challenges into opportunities, with those that are supposed to be making the decisions based on different other aspects and very minimally taking into account what is the lived experience. So narrowing the misunderstanding between the two languages might also help to bring to the attention of the policy and decision makers as much as possible what is a lived experience, but as we mentioned earlier, not to take it in an anecdotal way, but rather to give it a more robust and more scientifically rigorous approach when we try to bring the voice into the policies. I think that would make also a big difference.
Thank you so much. Dr. Anselm?
Good, fine, thank you so much. Now, this question, obviously, of obesity, it's a question that can take days to attempt to answer it. And really, as we know, the challenge really has been through the extreme marketing of diets which are high in fats, sugars, and salts, particularly sugars and fats in terms of the region of the Americas. And what we have seen when we've tracked the pattern is that the markets of North America were saturated. So then a lot of the private sector, the manufacturers of junk food and sugar sweetened beverages, then expanded significantly into the Caribbean and more importantly into Latin America. So we've actually produced documents in PAHO where we can show the change in terms of the marketing and the uptake of food, and then it tracks a geographical association with increasing obesity, particularly among younger people. So we know the drivers of the whole issue of the commercial determinants of health and the drivers for the obesity epidemic that we're seeing, particularly in Latin America. And in terms of tackling those issues, one of the approach that has tremendous impact, of course, is regulatory frameworks to tackle junk foods and the marketing to children, taking out the toys out of the boxes of cereals and the other things that attract children, and really pushing regulatory frameworks as well as taxation. This has had mixed results through the world, but I mean, the short answer, some of the best experiences we've actually had have been experiences from Chile in terms of warning labels, front of package warning labels. We've now built up a tremendous body of evidence, probably the best in the world, of the effectiveness of the octagonal front of package warning labels. But of course, when one tries to share the information and implement it, there's tremendous industry pushback. So taxes and regulation and earmarking for health has also been part of the agreement for the ADIBA agreements. And again, trying to change the environment through regulation and legislation is one pillar to tackle this issue. Another big pillar, of course, is the area of education and health promotion and health literacy. So populations understand what they're eating and what it means. And this is another pillar in terms of the approach. Then, of course, the environment, the school environment. Because if one can establish behaviors early in life in terms of proper nutrition, physical activity in the school environment, you actually change the trajectory of the cohorts coming behind. It's very hard to change obesity in adult populations. You get far more return on changing obesity in those who are most influenced. These are younger populations. So the school environment is a very major area where one has to focus the efforts. Healthy eating. And as I said before, very, very briefly, Brazil basically leads the world in much of its advice in terms of treating food not as ingredients, but as actual food that we eat and how we can enjoy it and how we can reduce the amount of ultra-processed and processed components and have healthier components. And of course, then it speaks to the need to strengthen familial farming and linking that to procurement. And again, procurement has been done very well in Brazil, where the government actually will procure quality foods from certain producers as opposed to junk foods. So I think changing the environment, changing the way you source, changing the literacy, changing the knowledge is all part of it. And of course, the other component, of course, is improving physical activity. Quite often we have forgotten that at least when at my age, I think you guys are a little younger than me, going outside and playing was very much part of how we lived. Now, the whole idea for kids is sitting there and the only exercise to get is to move their thumbs on some sort of video game. So the whole idea in terms of physical activity being part of the daily life is something that we have to reinforce, make it available in the school system and encourage after school activities. So getting back to basics. So I hope that answers the question to some part, but it's a very large and very complex topic. Thank you.
Thank you so much, Dr. Anselm. I'd like just to add one small piece, which is my motto here in our meeting since the second or first one, how the urban environment, how the built environment affects also our physical inactivity in cities and how our mobility options do affect also these abilities to be active. So I have a couple more questions. So one very quick question: will countries need to formalize the partnership with WHO to implement and monitor and evaluate the Global Diabetes Compact outcome? And a second one that I'd like to ask to all the panelists. The Global Diabetes Compact shows very clearly in its mission the prevention, the access to health, the role of engagement of people with diabetes in achieving its goals, and then with the activity or the pillars: protect, detect, treat, and recover, very clearly in each phase and who is targeted and how we can promote health with those pillars. So I'd like to ask you, how can meaningful engagement of people with diabetes or other NCDs can support and can improve the outcomes of these pillars and activities of the Global Compact? So these are the two questions that we have at the table.
Okay, I will begin. I'll also put in Guide to give a perspective from headquarters, but very certainly the Global Diabetes Compact, what we have now is the big vision, the strategies that we are quite sure will make the difference in addressing the burden of diabetes, the access to medications, inclusion in universal health coverage, among others, engagement of patients, engagement of whole of society. So what we have is the big framework, the context, the ask. So the next steps now will have to be how to develop the roadmap, how to implement, how to put the meat and the bones, right? How to fill in the gap. So this will be a process that will be an iterative process with the countries and member states, and a series of discussions will take place as one fills out the big vision and operationalizes it. So the question still is that we have the big idea, the big vision, the blue sky thinking. Now we have to land it and make it operational. Okay, so in other words, so I can't give you the answers as the pieces now being developed in consultation, right? So I think all those issues that you raised will be considered, and I think there'll be a really definite framework with all the steps of the process, but that is going to be developed now going forward. Guy, can I pull you into this discussion?
No problem. Happy to come in because I think that was spot on, Anselm. I would just add that one of the basic principles of the Global Diabetes Compact is the co-creation with the community that it's building. So Ansem is exactly right. The blueprint, the outline, the purpose, the mission, the vision, the pillars have been already put forth, and they have been put forth through a collaborative approach with the stakeholders involved. Going forward, it will be a medium to long-term journey, which will continue a dynamic process of really putting the pieces together. And that has been that's a conscious decision. It has been well thought out. And ultimately, the Global Diabetes Compact is a global, international partnership, collaboration. And each of these pillars will be developed down the road and co-created with the different stakeholders that involve, obviously led and focusing on country impact and led by member states. But it will also very strongly invite private sector, civil society, academia, science, evidence, to start building these different pillars. And each of these pillars will then span out and dovetail into particular activities. There's already some ideas, but all of these will have their own particular groups and multi-stakeholder groups to sort of really co-create this. Now, across all of these pillars, and that goes maybe, this sort of links to your second question that was directed more to ourselves, that all of these pillars will have an undercurrent of involvement, of meaningful engagement of people living with diabetes. And that has already started, actually. I was mentioning the launch of our report on people living with diabetes, but immediately that consultation was in December. Already at the beginning of this year, in April, we sort of already went forth as a second step from that December consultation and sort of also supported the NCD department at WHO HQ to have a particular consultation with people living with diabetes that we did in December to inform and to start the community of people living with NCDs to be involved and engaged in co-designing the Global Diabetes Compact going forward. So it's a very conscious decision. First of all, I'm involving people living with diabetes, but also a conscious decision of then having a multi-stakeholder approach to implementing the different pillars going forward and designing it with those expertise and those insights. Back to you, Pedro.
Dr. Nida, if you'd like to add anything, please feel free to.
Yes, very briefly, and apologies, I cannot really refrain myself from mentioning again the COVID and the lessons learned, or the lessons we are still learning. We all too well learned that we cannot have systems big enough to answer to the need of everyone, especially with acute disease like COVID, and it's not even recommended or necessary. We are all trying to have more preventative, more upstream engagement of all the sectors to prevent from people coming into the healthcare sector for as long as possible, until they really get to the age in which some of the systems normally or naturally fade away. Now, with this being said, if we draw this lesson back to other diseases, what we have seen through COVID is that there are huge communities and huge societies using the experience of patients who lived through COVID and how they coped throughout the disease or afterwards with the long COVID. In that sense, if we can really, beyond the policy level at the global, national, or regional levels, if we can at the system level try to engage this expertise in a more meaningful, more structured way to be an extended arm of those that have already coped with the disease or are living with it, to help the others, or their own observations to become part of the decision making for how to not let people reach out to bad choices or provide them more healthy choices. I think that can be something that we would be certainly striving for as a patient community, to try to share our expertise, not only for those that are going through the disease, but as well for those who can, be in the pool of those where disease has been prevented.
Thank you so much. Thank you, everyone. Dr. Ansem, did you open your mic to?
If I may wait just a few seconds. The second part of the question speaks to monitoring and evaluating the Global Diabetes Compact's outcomes. And I just will speak to that because that is such an important part of the work of PAHO and WHO. the fact that, as Margaret Han would say, if it doesn't get measured, it doesn't get done. So very much the whole philosophy of monitoring and evaluating and measuring impact is very much part of the philosophy. So that will most certainly be included.
Perfect. Thank you all for your very inspiring and very detailed presentations and answers. I think we've passed through all the questions, and we're very glad to have had you here in this opening session of our meeting. And I'll turn it back to Mark for the next announcement.
Thank you very much, Pedro, for your wonderful moderation, and I would like to thank Dr. Gaifones, Dr. Neda Milewska, and Dr. Anselm Hennis for their also wonderful presentations and speeches. I think very inspiring for the groups who will continue throughout the day today to discuss and also to work. So we have working groups on different NCDs and risk factors, and I'm sure that all of them will use insights that you shared with us here on the engagement of people living with NCDs, and obviously on the demands and lessons from the entire health community and the Global Diabetes Compact. There is, obviously a need now to respond to this huge number of deaths and of people living with NCDs, and also the numbers we saw in diabetes of the increase of people developing diabetes and people undiagnosed and people dying of diabetes, which could be many times, as we know, prevented. So, and besides hearts that, in the opening also, Rafael mentioned that is now a mission in Brazil. And this clearly will be a mission that will help also to have the Global Diabetes Compact succeeding here. So to achieve the goals of the Global Diabetes Compact in Brazil. And Guy, thanks for all your efforts for engaging people living with, and this call for all the different sectors and governments to keep engaging. I think that there is still a long way there to go to make sure that people are truly engaged in the decision at the decision tables. But it is wonderful to have WHO leading the way, opening the door, and I think this is very encouraging, and towards a brighter future, healthier future. Thank you all very much.
Thank you so much, Mark, and the forum. Thank you so much.
Thank you.